Hello, and thank you for joining us today for this OncLife Peer Exchange panel discussion on the topic of advanced colorectal cancer. Research and treatment advances have continued to move colorectal cancer treatment closer to a precision medicine model, and more patients are surviving long enough to require later lines of therapy. Today I'm joined by really fabulous people. Our panel of experts will discuss the role of molecular testing, frontline treatment options, and sequencing decisions that are rapidly altering clinical practice. My name is Dr. John Marshall. I'm a professor and chief of the Division of Hematology Oncology at Georgetown University Hospital and the director of the Rush Center for the Cure of GI Cancers. And I'm joined today by fabulous folks, as I said before. Way on my left, Dr. Tony Saab, who's the co-leader for the GI cancer program of the Mayo Clinic. Dr. Kathy Ng, Associate Director for Colorectal Center, MD Anderson Cancer Center of Houston, Texas. Dr. Dan Haller, Professor of Medicine at the Abraham Cancer Center at the Perelman School of Medicine of the University of Pennsylvania in Philadelphia. Dr. Tara Seary, who's the Associate Professor of Medicine at UC Irvine Health Chow Family Comprehensive Cancer Center at the University of California in Irvine, Orange County. Welcome.
Thank you.
Glad to be here. So thanks everybody for joining us. Thank you guys for joining us. Let's dig in. There's a lot of ground to cover. Kathy, I'm going to pick on you first. So nowadays, we are doing molecular testing for almost all kinds of cancers. And the story in colorectal cancer, it seems every year the story changes. What should we be testing today? Give us the update. What's your standard? What's the standard at your center? New patient metastatic colon cancer, what are you testing?
So for every patient that comes through that's newly diagnosed, we definitely test them for not only KRAS, but an extended RAS analysis, including NRAS and HRAS.
So what if I already have a KRAS in the bank and it's wild type? What do I do then?
You need to do an extended RAS panel analysis.
I got to send it again? What if I got no tissue left?
I would definitely do a new biopsy.
You got to do a biopsy, okay.
Because you'll identify at least an additional 13 to 16% of extended RAS mutations that could impact your treatment despite being KRAS wild type.
Okay, sorry, I interrupted. So RAS, I got to do RAS.
You got to do RAS. You should also do BRAF because that's a poor prognostic indicator. And obviously there's good clinical trials at this time for the BRAF patient population. And we do test all of our patients for microsatellite instability nowadays.
So right from the beginning, frontline, all patients, 85-year-olds and 25-year-olds, you're going to test MSI?
It's part of our panel.
Yeah, and we'll talk a little bit about why that's an important part. Anybody differ? Any other testing that you're doing routinely? Dan, RAS, BRAF?
We get
MSI.
the same panel as Kathy, and one of the questions I always have for myself is, although BRAF doesn't direct your therapy, it certainly directs prognosis. Mm-hmm. And you know, in my heart and in my head, I have differing ideas about how do you impart that to patients where they're reading about 33-month median survivals, but that patient with the BRAF mutation probably has a survival of a year or a little bit more.
Do you tell them that?
I actually do share it with them in the best way possible, as we always do with poor prognostic situations. I think that it's fair and it's good to tell them that. And it really impacts on thinking about, worrying about fourth-line therapy because they don't get there.
And how are you doing this? Is this your all's internal panel at your big cancer center?
It is. It is our internal panel that we're running, and actually it also includes HER2 new testing.
I was going to say, so I was going to ask, HER2 on everybody right from the beginning?
It's currently part of our upfront panel, but I think that's really important because you're going to see it in a clinical trial.
Okay. Any role, Tony, for broader molecular testing, you think, than these key elements that we've laid out right now?
You know, other than the ones that were mentioned, I don't think that there is a need to expand it any further, at least when we're thinking about our first line or two of treatment. Beyond that, I think it may become relevant, especially when we have more of these targeted trials into these different baskets. But from the get-go, I think RAS, BRAF, MSI definitely, plus minus HER2 would probably be your best bet.
Are there any differences at Irvine that might influence practice for others?
No, but one thing to remember, if your center is not doing the extended RAS and you need to send it out, a lot of companies will do that. A lot of them will also check MSI, but it's a separate test. And so you have to make sure that you specify that you want that also.
Yeah, so let me pick on you a little bit. Why do we need MSI?
So in the past, we used to just do MSI for stage 2 cancers. to see if they would benefit from the 5-FU or not. But now in the stage 4, when we realize if they're MSI high, they'll benefit from a checkpoint inhibitor. Yeah. And so this is, what everyone is talking about are checkpoint inhibitors, and this is this little fraction of the patients that will benefit from it. So it's definitely worth checking right now.
So everybody, all colon cancer patients, stage 1 through 4, everybody doing MSI in all of those? How are you testing MSI?
Well, everybody gets MSI testing by IHC originally. That captures about 90% of your patient population, and then we'll do an additional, if we really have a high suspicion, we'll do the additional PCR testing.
This is so hard and complicated that in our little conference room that you used to hang out in a long time ago, we actually have up on the wall, one of the things we posted on the wall is how to interpret MSI testing, because there's 4 proteins and one's missing and the other one's not, then it's maybe not a big deal, and it depends. So is everybody, anybody got a simple solution for MSI interpretation? Or does everybody have a little thing, you look it up on your phone or you have it memorized?
I look at the interpretation of the pathology report.
I call Stan Hamilton and MD Anderson.
Well, that's right.
Because I trust my pathologist.
But so the pathology report is confusing too, right? It comes back present.
Very, very complicated.
Right? And so everybody thinks they have it, but in fact that means the protein's there and normal, right?
Yes,
MSI
exactly.
stable.
So you're MSI stable when it's in that setting, right?
And so if I can advertise, because I'm editor of ASCO University, we put in place molecular oncology tumor boards in January of last year for this very reason, is that docs order these tests that came back with multiple results, but they don't really know how they're done or how they're interpreted and which ones are actually actionable. That you can move on. And I think with MSI, the issue is it's actionable, and what will the FDA require to actually approve the drugs? Will it turn into breast cancer with response rate, or is it going to be overall survival?